Hello, I'm Dr. Jeremy Reed from Virtua Health in Southern New Jersey. We are here to do a Mako Total Hip 4.0 from a direct anterior approach. I'm going to orient you to everything that you can see here. I'm on the ipsilateral side of the patient for hip replacement. To my right, your left, is the camera, which will be visualizing the stereotactic arrays. Right behind me is the robotic arm, and off to your right, my left, is the guidance module and your Mako product specialist that takes you through the case. So now we'll look at the Mako Total Hip 4.0 pre-planning screen. This is the enhanced planning screen based on a three-dimensional model or virtual model generated from a CT scan preoperatively. You also can toggle to a generated X-ray view. You can see certain landmarks here and axes that have been drawn. There is a horizontal axis generated by the anterior superior iliac spine of both the operative and the non-operative hip, and likewise the most prominent point of the lesser trochanter of both femurs, and a midline created at the center of the pubic symphysis and the vertical plumb line. This axis can be adjusted and set manually using alternate landmarks. Clicking the button allows you to draw a line, for example here at the teardrop of both the operative and non-operative hip, to reset the starting differences in hip length and combined offset. So you can see this square at the bottom shows the preoperative status of our operative left hip compared to the right hip. We are 1 millimeter shorter in length and 1 millimeter greater in combined offset. This axis can be drawn using the obturator foramen and also the ischial tuberosities if you believe those to be more clinically appropriate. After that, we begin with templating of the stem, and we can go to our raw CT data with our superimposed stem and get a look at fill and medial lateral fixation, as well as fixation in the sagittal plane if we're using a alternate prosthesis. In this case, I'm using a tapered wedge and or a blade type stem, and a fit and fill type stem may give us more information in the sagittal plane about when we're getting significant diaphyseal fit distally. Here we have a size 4 stem, and I like to track it from its proximal point of fixation down into the diaphysis, looking for areas of impingement and whether or not we are going to have enough room in the canal to fully seat the implant proximally. You can see here on the right-hand side that our native femoral version is -1 degrees, and that our stem version is presently at 8 degrees. Given its appearance on the cross-sectional images, I think I'm going to medialize slightly and add slight varus. I may also slightly increase the anteversion to improve its fit in the canal. You can see now that it's having less contact with the canal distally. It is clearly engaging but not violating the femoral calcar, and then also immediately adjacent to the medial neck. At this point, this stem is generating a hip length of 2 millimeters shorter than the opposite hip, but right at or about our preoperative status. We also can then take a look at our neck cut view, and this will give us an idea of how to orient our initial broaches as we start to instrument the femur. So now we turn our attention to the acetabular component. We are on the reaming cup view screen. In the top left-hand corner, we have the raw CT data in all three planes, transverse, sagittal, and coronal. You can see the magenta dot corresponds to the native hip center or center of the acetabulum, and the green dot corresponds to the prosthetic center of rotation. So in this case, we are choosing a 56 millimeter cup, and you can see what our values are in the top right of the screen. Our intended inclination of the acetabulum is 40 degrees, version is 20 degrees, and we've moved the center of rotation 1 millimeter superior, 3 millimeters medial, and 1 millimeter posterior. I like to visualize this through all of the planes to maintain fixation with the anterior and the posterior column, specifically in the transverse view, and also noting that I'm going to have no prominence of the anterior flange of the component that might otherwise cause iliopsoas impingement. I look to see if there's going to be any bony deficiency, anterior or posterior, which might influence placement of my component or my size. The sagittal view also confirms the appropriate position of the component in the sagittal plane and corrects for any bony deficiencies. And finally, in the coronal plane, as I scroll through, I'm looking for any cystic change that may otherwise compromise fixation and may influence my decision to use adjuvant screws. I also like to see the bottom of the acetabular component, or the inferior aspect, at or about the level of the teardrop for appropriate sizing and position. That said, the center of rotation is completely in the surgeon's control and can be set according to whatever clinical goals are at hand. Then we look at the three-dimensional model, or the virtual model, with our prosthetic in place, and we can look at it from every angle, and specifically the intraoperative perspective from the anterior approach. And we can see where we may expect to see overhang, where we may expect to see prominent osteophytes that may reinforce and confirm accurate placement of the component. Finally, with the acetabular component, we have the power to use functional positioning tools based on preoperative assessment of pelvic tilt in both the standing and the seated position. This can be assessed from preoperative radiographs, lateral views of the lumbosacral junction centered on L5-S1, and measuring either the pelvic tilt or the sacral slope. In my practice, I tend to use the sacral slope as it is the most reproducible and easily measured. For this patient, the sacral slope and pelvic tilt, while lying supine in the CT scanner, are measured here and are given as default values. These are used in creating our initial values for inclination and version. On this patient, in a standing position, we measured sacral slope at 45 degrees. And so we've entered that. You can see the functional cup position that is created by that. There is a slightly reduced version and combined version, but the inclination remains static. You can see here that the standing pelvic tilt is 3 degrees anterior compared to supine. This is within normal limits. It can also be displayed as an absolute value if that is easier to interpret. In my practice, I use this to tell me that a anteverted acetabulum will be slightly less anteverted in cases where the change is anterior, and conversely will be slightly more anteverted in pelvic tilt, which is more posterior. Likewise, in the sitting position, we have a sacral slope measured at 25 degrees. This represents a fairly normal spinal-pelvic relationship with somewhat normal mechanics between 10 to 30 degrees difference in the standing and seated position. In this case, it's 20 degrees difference. We are 3 degrees anterior to our supine position while standing and 70 degrees posterior while sitting. The enhanced planning software allows us to visualize this explicitly. So here we have the generated X-ray view from the lateral, demonstrating the supine anterior pelvic tilt as the plane between the pubic symphysis and the anterior superior iliac spine. As we showed before, it is 4 degrees posterior to the vertical plumb line. Sacral slope in this position is 42 degrees. If we click on the standing position, you can see that the anterior pelvic plane has rotated 3 degrees anterior. And you can see that the absolute value is 1 degree, whereas the sacral slope has changed to 45 degrees from 42. Likewise, the sitting position, you actually see the model rotating backward 17 degrees from the previous supine position and 20 degrees from its position in standing. That is the sum of 17 degrees posterior and 3 degrees anterior. The anterior pelvic plane has rotated backwards. The sacral slope has reduced now to 25 degrees, and the pelvic tilt is now 21 degrees posterior. This has significantly changed our functional inclination, and we now have 46 degrees of inclination and 32 degrees of version in the seated position with much better posterior coverage of the acetabulum. This is exactly what we're looking for in terms of functional stability of implants that is dynamic, both in seated and standing positions and in activities of daily living. So now we take the position of our components to the virtual range of motion screen. You can see at the bottom left we have positions of the femur and the hip joint, both in standing and seated position. We have our prosthetic components within the virtual model, and we have our planned length and offset compared to our preoperative status on the bottom right-hand corner. We can click on the lateral view, and now we can see the relationship of the pelvis and the bony and prosthetic acetabulum. If I click on the standing position in 5 degrees of extension, we can see the femur externally rotating. Until a shadow appears along the liner. This is an area of prosthetic impingement. At this point, we are fully extended in 55 degrees of external rotation without abduction or a deduction. This would be clinically acceptable for many surgeons, and so this would not influence my decision to change the position of my components. If we go to the seated position, and once again we have the femur in place, we can see in 40 degrees of internal rotation and 90 degrees of flexion with appropriate pelvic tilt rollback, we don't have either bony or prosthetic impingement. With increasing flexion, we can see the beginning of bony impingement and then prosthetic impingement. These things can be corrected by multiple means. We can begin to increase the version of our acetabular component and reduce our prosthetic impingement. We also can change our inclination to reduce it even further. For bony impingement, if we are not planning to do a marked bony resection of the area involved, we may be able to introduce additional length and offset, and you can see its immediate effect on our postoperative hip length and combined offset compared to the other side. In this case, the patient has sufficient flexion for activities of daily living, and if we reduce the internal rotation to a neutral position and bring it back up to the same position of flexion, we can far exceed our previous limit. So this would correct any bony and prosthetic impingement up through 120 degrees of flexion. All of these options are available in the virtual range of motion screen for any combination of elements. Here we have our generated X-ray view of our final component positions within the virtual model and our intended hip length and combined offset. So now we will place our pelvic array. This is the contralateral iliac crest, and I've drawn out the margin of the anterior superior iliac spine and the iliac crest as it sweeps posteriorly. This is the distal leg, and this is the abdomen. So we measure a couple finger breadths below the anterior superior iliac spine and position our drill sleeve. I make 2 marks in the skin for the position of the pins and place a stab through the skin, and also for the third pin, which we will place later. Next step is the hemostat. We want to clear off periosteum and be able to palpate the inner and the outer tables of the pelvis. Once we have that, we can position our pin clamp right in the center of the iliac crest. And we try to get at least 3 to 4 centimeters of penetration to optimize our fixation. Once we have our first 2 pins, we may have to broaden that central skin incision so that the tube of the drill sleeve is resting firmly on bone. Finally, we attach the array. And we want this to be oriented towards the stereo tracking camera at a slightly increased angle up towards the ceiling in anticipation of banking or airplaning the table away from the patient, or excuse me, away from the surgeon, to have the best possible line of sight during registration. So as part of the pre-planning, we have a digital ruler function that allows us to measure discretely from landmarks in the patient's anatomy to the templated osteotomy line for our femoral component. You can see that we have the opportunity to draw 3 different measurements. The first measurement that I use, I try to find a specific anatomical location that's unique, and we can see that there's a divot in the anterior femoral head-neck junction that has just been selected, and we can draw a line down to the medial neck cut. So that's about 37 millimeters. As a secondary measurement, we can position a point at the medial femoral head-neck junction, or inferior. Oftentimes there's a large osteophyte here, which can give you a specific and very reproducible point. In this case, we're just going to use that change in direction at the actual junction in the absence of a large osteophyte. You can also use a third measurement. In the anterior approach, I tend to use only 2 measurements, and the most proximal exit point of my osteotomy is always at the superior neck or in the saddle, and not proximally, or rather distally, as in this drawn line, which would go into the trochanter. Now if we turn our attention to the patient, this is the anterior divot at the head-neck junction. We'll hit capture. And then move distally to the point on the femoral neck and make an appropriate mark. Then we'll select our second capture point at the medial junction. Capture. And move it down to the same point to confirm the correct position of the neck cut. So we now have our acetabular exposure, and from the anterior approach you can see we have retractors exposing the rim. We've performed a labrectomy and elevated the pulvinar, and part of the superior aspect of the rim where we can place our pelvic checkpoint. You want to orient it away from the fossa so that it is not engaged during reaming. We pull it out and remain coaxial so we don't toggle the checkpoint, and then we place our probe in the divot and verify our checkpoint. So for our superior landmark, we're taking points from either the divots in the pin clamp here with the black circles around them, or from the bone itself on the iliac crest, which is what we're going to do in this case. I'm placing it firmly in the center of the crest in the blue highlighted region that you can see on the virtual model. Now we're going to select 15 points around the cotyloid fossa in the articular space, moving sequentially from anterior to posterior. These points are selected in advance with you and the Mako product specialist to take advantage of the most consistent bone and that which is best seen per the approach. So for the anterior approach, we may need more posterior points than anterior. Now we're selecting our posterior landmark. We are careful to place the tip on bone. If it needs to penetrate cartilage or labrum or periosteum, we make sure to do so without penetrating the bone itself. This anterior landmark is selected at the notch, and this may be at the change in direction of the anterior wall or closer to the anterior iliac spine. Now we take extra-articular points. spreading them out several millimeters apart, and again being careful to place the tip of the probe directly on bone. Points that are further from the rim can be helpful, and scattered with points that are closer to the rim as you move from anterior to posterior. So now we're in the verification screen. You can see our collection of points. Green would be less than a half a millimeter to plan, and yellow greater than that. Each of these verification spheres requires not only accuracy within a millimeter, but also stability. And now we have the green check mark at the top left of the screen indicating a passing registration. So now we have a valid registration. We're ready to ream. I take the reamer freehand and position it into the wound. And then we take the end effector of the robotic arm, thread it over the top, and select the offset setting. For the direct anterior approach, we tend to select a 90-degree setting, and that corresponds with the setting at the guidance module. We then position the power mix, and you can see already on the screen that we have engaged the haptic field and cone with the spokes on the wheel in blue. You can see the axis of the reamer moving. You can see the actual and planned version numbers at the right of the screen, and you can see the yellow target center of rotation in the middle of the acetabulum. We have 5, 8, and 4 millimeters to go to plan. So here we have numbers flickering 0 inferiorly and posteriorly between 0 and 1. We've reached our target center of rotation. The red is slightly past plan, but not clinically significant, as we've reamed a hemisphere. We have a 3D printed Trident 2 shell. Position it in the wounds, and we use the butterfly to position our screw holes. And then again, we thread the end effector and place the impaction pedestal. The MPS has locked in the inclination inversion, and presently we're 11 millimeters proud. We have impacted to plan, and now we unscrew the butterfly wrench. And retract the arm. You can see that we're fully impacted, looking through screw holes, and we can go to our cup view on our virtual model and see exactly where we anticipate overhang from placement of the prosthesis. And we can see that we have that here, superior and posterior, just as we do on the virtual model, as well as osteophyte peeking out inferomedially. So we're confident that we have achieved our planned cup position. So here we have our femoral exposure. This is the neck resection view on the right that gives us our angle of attack with our starting broach as we begin to prepare the femur. You can see that we have both the anterior and the posterior aspects of the neck visualized. We have the medial neck, medial calcar, and here is the far lateral point of the trochanter, piriformis fossa, right along here, and so we can see that our planned broaching angle will be right along this axis. So we've come to the end of our broaching. You can see that we have fully seated our broach, and it's in the intended anteversion, originating at the shoulder here in the piriformis fossa, and then coming towards the anteromedial neck. We have our final broach in position. We had very sclerotic bone along the medial neck and a 3 seated adequately with good fixation. So we will change our plan to a size 3. We've placed our trial liner, and now we'll apply a trial neck with our 2.5 millimeter head and achieve our reduction. Good. So we're placing the limb in our original position for the initial limb length and offset measurement. We then isolate the trochanteric checkpoint and capture, and then at the distal EKG lead, capture. So you can see that with this plan we are 3 shorter and 2 increased in hip length and combined offset compared to the opposite hip, and we are 2 millimeters shorter and 1 increased from our preoperative hip. So in order to come closer to plan, we may add another 2.5 millimeters of neck length, or we could use a 132-degree neck angle stem to both increase our hip length and decrease our offset to come closer to the opposite hip. So now we have replaced our trial neck with a 132-degree neck and a plus 2.5 millimeter head, and we're going to retake our limb length and offset measurements, capture, and capture. And so now we have a more faithful reproduction of our preoperative plan without any change in length or combined offset from the contralateral hip. And this is the Mako Total Hip 4.0 platform from the anterior approach.